Go ahead.
Thanks, Gabby. Pleasure to present at Grand Rounds, and actually it's an honor to do this, albeit virtually. Tricuspid regurgitation is the thing in question. In reality, actually, the talk should be transcatheter treatment and actually a functional tricuspid regurgitation, and I'll get into the details of it, but that's largely what we're talking about in 2020. Don't have any financial disclosures associated with any devices that are being shown, but some of the devices are off-label, and actually the two or three of the cases are early feasibility and pivotal trial patients. This is kind of brand new stuff as of 2019 and 2020. Hopefully there's a good quorum of fellows and others, but I think I thought I'd start with the anatomy of the tricuspid valve. It's the largest of the valves, often called the forgotten valve, along with the forgotten chamber, the right ventricle, that is, and it's the largest of the three. Hopefully you can see my mouse here. There's the septal leaflet, posterior leaflet, and anterior leaflet. Anterior leaflet's usually the largest, and actually there's often division of the anterior leaflet into multiple scallops, resulting in some confusion as to whether it's actually a 3-leaflet valve or so on, or more. There's a papillary muscle attached to it on the anterior side, and then there's kind of variation in the posterior and septal papillary muscles. 20% of humans don't have a septal papillary muscle. What happens with that is that there's direct chordal attachment from the valve to the myocardium of the right ventricle. This makes it particularly prone to insufficiency. A reason being, whenever you dilate out this way. There's a fibrous band here associated with the crux of the heart. There's no fibrous continuity with the pulmonic valve, as we know. So whenever something goes amok, so dilation of the heart in general, you end up dilating out the anterior direction, a little bit in the posterior direction, and leaving a predominantly what's thought to be a gap in the anterior septal commissure. Much like the mitral valve, you end up losing this saddle shape, end up having this kind of flat annulus, which then causes a coaptation deficit as well as the dilatation. So it's an adverse response to volume loading largely, and the volume loading we're now understanding can be atrial, so atrial fibrillation and chronic overload of the right atrium, as well as the right ventricle. So, what we're looking at on transthoracic, so the slides are Becky Hahn's slides, or images rather, but the images are mine, and those acquired over the last 2 years or so. What we're looking at here is an RV inflow of stranded transthoracic. The panel A is looking at the septal leaflet. We know that because the coronary sinus is in view. And this is the anterior leaflet here. This is the RV free wall. And then we're looking at anterior leaflet and posterior leaflet in panel B. And I've just shown, this is a patient that will walk through the course of this talk. You see septal and anterior reasonable coaptation there, and you don't really need color there. There's a giant gap between the anterior and posterior leaflets in this patient. When we go to with the short axis, I usually, find it reasonably helpful in the short axis for all myocardial structures, but the tricuspid valve is particularly confusing, specifically also when it dilates. By and large, you only see the anterior leaflet, unless there's some kind of pathology, as we are seeing here. The anterior and posterior leaflets just simply not coapting. And depending on where you cut things, you can actually also see all 3 leaflets. But for the sake of simplicity, we can just say that you can slice it however you like on the short axis, and we'll get to that in a second. In the long axis, you can mostly, by and large, see the anterior and posterior leaflets. If your long axis is off axis, showing the coronary sinus, you end up looking at the septal leaflet. If it's looking at the aortic root there, you're usually looking at the anterior and posterior leaflets. But here you can see that it's of limited use, right? This patient, the same patient here, the right ventricle is dilated. We know that this is the anterior and posterior leaflets, but when we're off axis here, the coronary sinus is severely dilated from the pathology. It's not really clear what we're looking at. And that's kind of true in general. Again, the same patient, and this is 3D, and you can see that there's a deficit between the anterior and posterior leaflets. This was not a research patient. This is just a regular transthoracic echo, and the sonographer just happens to be excellent at acquiring these, and this is just a regular X5 Phillips probe. So these are easily obtainable images. Transesophageal, so anyone doing transesophageal echo will realize that the tricuspid valve is quite difficult to image, largely because it's the furthest away. So your probe is here, this is the esophagus, and the tricuspid valve is all the way back here, probably the second hardest in addition to the pulmonic valve. A couple of things work in our favor when someone has tricuspid valve disease or severe TR. The right atrium dilates in this fashion, the atrial septum moves and actually brings the tricuspid valve in plane. However, it's still a challenging thing to do, and you end up needing to use all your views. So the high esophageal, deep esophageal, and transgastric, which we'll go into depth during the course of this talk. We really need to make use of every single probe motion available to us. This is critical, including, so this is a CT of a patient with a dilated cardiomyopathy, just pointing out that the blue plane here is the esophagus. And you can see that there's the tricuspid valve is all the way over here. So antiflexion, retroflexion is going to be a limited value, and advance and withdraw is helpful. But what you actually want is this, and I found this particularly helpful. Right flexion, as recommended by Becky Hahn, is particularly helpful in getting challenging images to actually look decent during structural cases for the tricuspid valve. In the mid-esophageal view, we have basically the anterior and posterior leaflets by and large, and here's where orthogonal views are helpful. So when you look at a biplane image of the mid-esophageal view, you end up getting a short axis view, and this is particularly helpful to narrow down where the pathology is. Again, this is the same patient. I apologize for the quality here. It degrades when you put it in a PowerPoint, but we'll get some better images. The same patient here again. It looks like the same image, but there's some slight nuances. So here in the short axis, when you do an orthogonal view, you end up looking at the long axis equivalent. So here we're close to the septal leaflet, and we know that this is the septal anterior. We're going more central in this second image, and this is kind of an anterior posterior, and you can actually see that same gap there. And we're going posterior and septal in the bottom of the image, and actually looks reasonably okay there. This is done on purpose, and the same images with color show a similar thing and tells you where the action is really. So it tells you it's not here. It's not, you see color, but you're not seeing flow convergence. You start to see flow convergence in the anterior posterior and so on. So this is very good for figuring out where the disease is, and it's easier said than done, and it takes some time to kind of really narrow down. You can also see that this is not normal anatomy. The right atrium is pretty severely dilated. The septum is moving to the left. This becomes a technical issue with structural heart planning, which I'll get to. Incidentally, the patient also has a pretty significant eustachian valve. This is a separate patient, but just for example's sake, a transgastric short axis gives you very nice detail images of the septal leaflet, posterior leaflet, and a large anterior leaflet. In this case, has two scallops. So these are kind of the views that are essential. Back to our original patient, you see that 3D is obtainable pretty reasonably and reliably. This is not even with trying to optimize the image, and I'm making a point that you can get these in diseased patients much easier than normal patients. Incidentally, you also see that there's a wiggler on the aortic valve here, which becomes important in a second. Optimizing the gain a little bit gets you to the point where you see the anterior-posterior defect, and overgaining is a challenge. One of the things I didn't quite appreciate as I was until I was starting to do these is the relationship of the coronary sinus, the IVC, the right atrium, and actually where in space the tricuspid valve is. And I think live 3D is particularly helpful for this. So usually, so the coronary sinus is up here, the inferior vena cava is coming in here, and this is the SVC here. The tricuspid valve, if you use 3D, is over here, and this poses a technical challenge with tricuspid valve interventions, and you need specifically designed catheters for this. Of course, there's 2D and Doppler assessment of severity, triangulation of the CW Doppler curve, IVC dilatation, and hepatic vein reversal, all kind of a given in this patient population, but really important to do. A lot of the time we neglect to do things like hepatic vein Doppler, for example, in patients with borderline mild moderate TR, and that's an important thing that we'll go into in a little bit more detail now. So this is the grading severity scheme for TR, and I think a couple of things weren't pointing out, so I'm just going to highlight them here. I think we're in general pretty good about saying, yeah, someone has severe TR. There's dense CW pattern. Usually it's quite obvious. There's reversal of hepatic veins. And we're reasonably good at saying it's mild when, you know, by visual estimate is largely the case. We don't usually do things like tricuspid inflow PW and such unless you're at a tricuspid program. The thing that's confusing about this guideline is that the entire definition of moderate is it's somewhere in between the two, or you have to do some kind of quantitation, which is unusual. I'm speaking of this in particular because there's some outcome data related to tricuspid regurgitation that's important to delve into, which we will do for about 5 minutes. But so in general, we're reasonably good at this. We're okay at this, I think, and we need to work on how we decide what's moderate. The reason is as following. So when you have mild tricuspid regurgitation, you can be fooled in case it's moderate. So when you think you have mild, rather. So you are reliant on visual estimate by color, and the fallacy in that is to do with physics. So for your eyes, you're usually trained to see mitral regurgitation. And just for example, an EROA that's the same for my MR and TR, a 5 meters per second, so normal blood pressure MR jet will have 4 times the color than a 2.5 meters per second TR jet. So unless you train your eye or do some other non-qualitative measure, you could be missing a whole bunch of moderate TR, which is the point that I'm trying to make. So quantitative is almost always superior to qualitative, and that's by and large the case, but sometimes there are limitations like busy labs and so on. But it's worth looking into. There are trials and studies that were plagued by severity grading of TR because people in the mid 2010, 2015 timeframe were wondering, you know, some of the TR, for example, these gradings are kind of way beyond severe, which is in the guidelines. And this scale was proposed by Becky Hahn. Looks like it is reasonable as of 2020, and people are proceeding with this. But again, still not much in the form of outcomes data. So we're going with this, but we're not really sure about the outcomes with the different scales. All this to say, I think if you're a sonographer listening to this, I think I'd say if your gut feeling is that the TR is more than mild, you need to do a lot more to figure out if it could be moderate. And that's tricuspid inflow pulse wave, flow convergence, and specific set Nyquist limits, and shifting your baseline to get PISA, if only to get flow convergence. And also kind of definitely don't forget to pulse the hepatic veins. Lastly, I think one of the fun things is to play with the 3D, and the more you do it, the more you realize actually it's pretty straightforward. As for a clinician, I think if you see TR that's anything more than mild, I think there should be a low threshold to figure out what's going on. And certainly think about additional imaging if your TR is severe, and I don't think we should be sitting on it. The reason is as follows. So tricuspid regurgitation is a bad problem to have. This is a cohort of patients from the West Coast VA system as far back as 2004. And this is adjusted for LV function, RV function, PA pressures, and the presence of arrhythmia. So independently of all of that, I think we can see that there's a couple of strata. So there's no TR, there's mild TR, then there's moderate TR, and then there's severe TR. And just pointing out, just under 2 years of follow-up, the outcomes are not great in terms of survival. Again, observational data, but that's what we need to figure out. And this is very recent data from 2020, a really nice, elegant group from Israel doing a lot of work in this. And this is close to 30-some thousand patients, and they are showing actually very similar things in that there's clear separation of moderate and severe TR and outcomes. Excuse me. This is again the same group, and they asked the same question I just asked. You know, is the severe, moderate, and mild based on outcomes? And it turns out there's good separation between severe and mild when you compare it to matched controls, but we still don't know about moderate. So they took it a step further. Same group again, and they said, well, why don't we do the EROA as a continuous variable and figure out what's a reasonable situation to describe. And it turns out that actually moderate, as per the survival curves, is actually not a bad thing, not a good thing to have either. And an ERO of 0.35 seems like it has a clear kind of outcome-based implications for patients with TR. So in general, it's a bad thing to have. And unfortunately, we can probably close to definitively say isolated TR surgery is also not a good thing to have. Frankly, hasn't been successful. This is data from the US, inpatient outcomes data saying that, for over a decade, inpatient mortality for TR surgery, isolated TR surgery, is about 9%, despite volumes going up, because we're recognizing there's a need to fix this. So there's clearly, we have to be doing something. We can't do nothing, waiting for patients to decompensate. But what we're doing as of 2013 doesn't seem to necessarily be effective. So kind of what are the options available? There's a few. I think initially there was enthusiasm about putting in transcatheter valves in the cable positions using grafts. This was the Hover trial. It leaves the tricuspid valve in place, the incompetent tricuspid valve, which leads to adverse remodeling downstream in the ventricle. So that hasn't particularly borne out to be useful. Tricuspid annuloplasty, I'm not talking about today necessarily, but has some encouraging data from transcatheter therapies such as Cardioband and Millipede and other devices. Then there is a spacer system, which tries to plug the gap that you see on echo, which is called the Forma device, which has been reasonably successful. I have no experience with it. And then there's those who've already undergone an annuloplasty can get a valve-in-valve, which seems to be a reasonable thing. And then what we're talking about today, and I'll show you a couple of cases, is transcatheter edge-to-edge repair, kind of like we have for the mitral position. This is data from an international registry of tricuspid interventions. You can see that the majority of patients ended up getting a mitral clip in the tricuspid position on a compassionate basis. The rest of these devices I kind of briefly touched on. This is a group of high-risk patients who had severe symptoms. And we see that just from a collaboration between European and US physicians, that there's significant benefit to doing nothing. And freedom from heart failure and survival seems to be reasonably robust in terms of kind of following these patients. Now, granted, these are cherry-picked, right? It's not a randomized control trial by any means, but there seems to be some suggestion that we could be doing more with these devices. Here's data from that same registry looking at symptoms. Now, by and large, at baseline, people had class 3 or 4 symptoms, and we are able to reduce them in a sustained fashion over time. And it's largely based on how well you reduce the TR, obviously. So I think that was encouraging. This is procedural success of the actual device dictates how well you do in terms of survival. That makes complete sense. There are a couple of predictors of what actually does help and whether or not you have adequate coaptation and whether you have a annulus that's not exceedingly large seems to be predictive on multivariate analysis of this kind of small group. So delving a little bit more into the mitral clip and the tricuspid position. So this is Georg Nickenig from a really excellent center in Germany and really has spearheaded a bunch of this tricuspid intervention in general. Looked at 42 patients who underwent isolated tricuspid edge-to-edge repair, and they also had 22 patients, as it happened, who they kind of did a drive-by, so to speak, compassionate use tricuspid edge-to-edge repair at the same time as a mitral clip. Pretty sick population, older population, mostly female, and actually had a reasonable amount of pacemaker ICD placement. They, in general, were reasonably successful at putting in clips. There were no adverse events during the procedure. Most of the clips were in the expected anteroseptal position. And by and large, people needed 1 to 3 clips in general. They initially, as of 2017, thought that it was technically feasible. They tried a couple of things. One was the internal jugular approach. They didn't think that this was particularly helpful. And they had in-hospital tests that were felt unrelated to the procedure, arrhythmias, and so on. A couple of problems with the mitral clip in the tricuspid position. There's the steerability of the device, the location of the curve at the delivery end of the system. There's plus minus M and L knobs that to an operator will be familiar or more familiar than for me, certainly. But what ends up happening is that this is not really designed to be in the cavo-atrial junction. And if you can imagine the bicaval image that I showed you in the TEEs, this basically ends up hugging the atrial septum and causing issues. And here's an example of this. So here, again, apologies for the graininess of the clip. This is from Dr. Nickenig. You end up bringing your curve over here, and you'll see this in the case that I'm about to point out. And what you actually need is for your clip to be over here. So this is a kind of technically flawed issue with using the mitral clip. So anyway, back to the case, the images where I was showing you to define the anatomy is this 78-year-old lady, really nice class 3 dyspnea, 2 hospitalizations for heart failure. atrial fibrillation, which you'll see is a theme, and a high STS score. She was, by core lab, deemed to have massive TR, which we agreed with, and really unfavorable anatomy, a giant hole, tethered septal leaflet, and not favorable. They were, however, willing to consider it, except for the fact that she had a aortic valve lesion that was thought to be a PFE. For this reason, they said no, despite the appeal and such. So we decided to go for it because there were no other options for this patient. Here you can see this catheter. This is the mitral clip delivery system, and it's really unfavorable. It's not easy to bring it into the tricuspid annular plane, and you see the same issue as the images from Dr. Nicknig. This is hugging the atrial septum and not really playing well with us. Eventually, though, we do get into a situation where we are able to align this. This is a short axis view in the transesophageal, transgastric rather, sorry, plane. Again, very, very difficult to maneuver, a lot of bouncing around. We eventually get it across what is the septal leaflet and the anterior-most scallop of the anterior leaflet here. So we're aligning the clip. It looks reasonable. We have deployed this first clip here. Again, looks reasonable. And the idea is to bicuspidize the valve. So you try to get as many clips in this plane as possible of my mouse. So far, so good. And then we put in a second clip right here. You see next to the first clip. And we unfortunately had difficulties deploying this clip, or rather, we had no problems deploying the clip, and anyone who's used the MitraClip system will attest to the fact that releasing the clip is a little bit of a kind of landing an airplane situation, a little bit hairy. Deploying this clip was a challenge, and unfortunately there's problems here, and really despair, because after we released this clip, you can see that now both clips are only attached to the anterior leaflet. Not only that, we probably made things worse. There's anterior flail in the short axis view here. So what do? We need to stabilize the situation. It's unacceptable to leave it this way. So we put in a larger of the XTR clips of the mitral clip line and stabilize the situation. Actually, the result is reasonable and certainly not worse than how we left it. And we kind of called it a day there. So we unfortunately didn't change anything here. So massive to massive, and really kind of highlights a couple of issues with using the mitral clip in the tricuspid position. Now, I want to turn the attention to the tricuspid clip, or the tri-clip. This is, again, a specific device for the tricuspid clip, for the tricuspid valve. There's a couple of things. So there's flexion and extension, septal lateral movement, and the plus-minus knob. So this design change, in addition to changing the curvature of the distal delivery sheath, has, as I understand, really improved maneuverability of the device. So this is the second case. Now, this patient is an 89-year-old AFib, has a pacemaker in place, also similar idea, class 3 symptoms, and has heart failure hospitalizations. He has a history of a surgical AVR and has severe TR. So he was thankfully enrolled into the Triluminate pivotal study, which is 700 patients currently ongoing, looking at all-cause mortality, heart failure hospitalizations, and quality of life with the Kansas City cardiomyopathy questionnaire. We're pretty excited to be part of the trial, and this was our first patient. This was done at the University of Pennsylvania, and here you have the same idea. So the short axis view, this is around 50, 60, 70 degrees, depending on anatomy. And in an orthogonal biplane view, you see that this is the septal leaflet and the anterior leaflet where the action is. there is this pacemaker lead. It's not where the action is, and I hope I can convey that to you in the short axis. The lead is in the posterior septal commissure, not interfering with our assessment of the TR, and actually it's a reasonable thing to do. The core lab actually thought that this patient had 5 leaflets. As an aside, we thought again similarly that they have 2 anterior scallops, a posterior leaflet, and a septal leaflet, but regardless, favorable anatomy. Here is better images of grasping using this device, much easier maneuverability. And this is the first clip going in, same idea in the anterior-most anterior septal commissure. And then we have a good result here, actually, surprisingly. And then the second clip here, we didn't feel like that was a sufficient enough reduction. The second clip is going in the anterior septal commissure, but looking at the second scallop now. And the TR reduction is really quite good. This is the end result. So you have 2 clips here, both in the anterior septal commissures. We've kind of plastered this valve and have a pretty good result, at least by TE initially. And here we have TE by 30-day follow-up, showing the clips in very good position. This is inflow view, 4-chamber view with very little TR, obviously still massively dilated right atrium. And we improved things for this patient. They had severe TR by the 5-grade scale, and we went to moderate. This was back in June 2020, I think, and this patient has no longer had any heart failure hospitalizations, and the formal 6-minute walk test improved by several meters. So kind of good result there. This is from the early feasibility slide set. This is from the very recent PCR course, available online for any fellows interested. Showing that we really, for 64 patients, improved things from NYHA functional class 3, 4, largely to NYHA function class 2, 3 at baseline and into 1 year, with improvement. Dr. Weintraub probably can attest to this, that this is actually meaningful improvement in the KCCQ over time. We obviously, the success relies on reduction in TR, and there's sustained reduction in at least 2 grades of TR in this using this device. Similar idea with the NYHA functional class, kind of plus minus on this, but they looked at the patient's hospitalization rate pre-device and post-device. And showed a reduction. But again, same idea, procedural success dictates your risk of developing heart failure or death following, and this looks pretty robust. I think there's a couple of things that are important to know. So I think if you improve your TR grade by at least 2 grades in the 5-grade scale, that's a good finding, and that's what we see here. If you have a 1-grade reduction, we're not as good as if you have a more than 2-grade reduction based on the NYHA functional class. And then here's the other thing, and this is why I spent a little bit of time going over what's mild, what's moderate, what's severe, what's massive, and what's torrential. It seems like if you have severe TR based on the 5-grade scale, you do reasonably well with any device. If you, however, have massive or torrential TR, I think it's probably too late. And we're looking at a very late cohort of patients, and they probably are too far gone. So that's kind of the take-homes from the Triluminate, the data available. This is the CLASP device by Edwards. So 65 patients early feasibility study looking at procedural complications as of now. This is a patient that we enrolled in this study, 82-year-old, again, same idea, starting to get the gist of atrial fibrillation, heart failure hospitalizations with normal left-sided echo parameters with a giant gap, with severe TR, actually may have been massive. Same idea, you see that this patient has a pretty nice slit-like gap in the anterior septal commissure. I wanted to just impose on you this image of the left atrium actually being quite large and the right atrium being quite gigantic, and really kind of poses technical difficulties bringing catheters down here, as I'm sure you understand, which really relies on the fact that the steering is kind of key. Here's the classic workhorse view of tricuspid intervention. And I want to point out the gap that we saw in 2D, the same in 3D with color. Here you see the device sheath in the SVC-IVC plane and the tricuspid valve here. So we want to get from here to here, and we have our device lined up nicely, and this is largely due to a dedicated sheath. And again, we have very good grasping and a reasonable result with one clip here, and subsequently a second clip. You're getting the sense now that the anterior septal slit-like commissure is where the action is and where we try to reduce TR. And this is the end result here, which actually is a very reasonable result from the patient's previous massive TR. Again, the successful case, 2 clasps put in, anterior septal, and actually I think this is again the same idea with the second scallop of the anterior leaflet rather than the posterior septal commissure, and we went from massive to moderate. So those are 3 cases, the first of which was a compassionate use case. We really felt we had no other option. She was not a surgical candidate. The second case was the Triluminate trial patient, really great result. I'm really optimistic about the whole thing as a result of that case, in fact, during fellowship. And then the third case here, with the CLASP device, again with reasonable success, kind of showing that you need the appropriate tools to do the job. I think we've learned a few things, and I adapted this from the PCR content from just a month ago, and this is the European recommendations for edge-to-edge repair consideration, or putting patients forward for trials. Obviously, symptomatic severe TR, that shouldn't be an issue, but this is intentional, so it's not symptomatic massive TR and it's not symptomatic torrential TR. We have to catch them here at severe TR on the 5-grade scale, and there should be a clear culprit lesion that's actually able to be clipped. So not endocarditis, not destruction of the leaflets, etc. Central gaps with holes and such are not good, and the gap should be small. I was hoping to provide you some images of 3D ICE today, but I'm not able to do so because it was withdrawn by the FDA. But in case there's no good TE windows, 3D ICE with multiplanar reconstruction is a definite option. So who's ideal? Ideally, for functional TR, you should have normal leaflets. You should have severe TR. Hopefully, I'm imposing that upon you. You should not have a giant gap. If your lesion is in the anterior septal commissure, great. Ideally, you shouldn't have any leads, but I think I showed you a case where we did have a lead and we managed fine. It depends on where it is, and you should have normal RV function. Who's kind of plus minus? To be honest with you, we're mostly getting plus minus and not ideal candidates referred, but here's the case. If you have prolapse and some restriction, usually of the septal leaflet, not great. If you have massive TR, that's not ideal. And if your gap's pretty big, technically there's limited closure of the gap based on how big the device is. We don't have wide clips necessarily for now. So that's a limitation. And then if you have kind of posterior septal commissure or anterior posterior commissure even, that's not ideal. And then if you have reduced RV function and pulmonary hypertension without elevated PVR, you should think twice. And you can certainly consider pacemaker ICD leads, but as long as they're not interfering. And then lastly, kind of who should you not do? I think if you have severe leaflet abnormalities and restriction, you should really think twice. Torrential TR, probably, I think it's clear that we're too far gone. And then if you have the gaps, the broad TR cases, pacemaker lead impingement, bad RV function, and elevated PVR on cath, I think unfortunately those situations are not suitable for this technology in its infancy. Couple of ways that we've evolved our program, certainly here and definitely at Penn. This is a patient from here at the Lankenau Heart Institute. This is a patient who was 51, incidentally found to have a murmur in 2015 by her primary care physician, and had moderate TR at the time, based on MRI. And over time, now 2020, had this TE done and showed severe TR. But exercises 5 days a week, no functional limitations, no heart failure. Kind of, what do you do with this patient, right? I think CMR is a very powerful tool and should be used in valve cases, certainly when there's need for tie breaks. And I think there's a really nice cohort of patients published by the Houston Methodist group just this year, showing, again, similar to the echo data out of Israel, that there is clear risk strata. So if you are at high risk, meaning the high regurgitant volume, high regurgitant fraction group, you're at very high risk for adverse events. But intermediate risk is not benign, and there's kind of concern about that group. And then low risk is low risk, which is okay. This group of patients, about 300 or so of them, or just over 400 maybe actually, clearly demonstrating at least up to 1 year, until which point the data becomes a little less robust, that there's clear separation and or stratification that's possible by MRI at least. And this group published a very similar paper looking at their echo data, showing that agreement with CMR is reasonable, and actually CMR is a little more precise, which makes sense based on everything we know about the MR space as well. So what did we do with that patient? We kind of have continued to follow her with cardiac MRI. She has, these are non-contrast studies, and you can kind of clearly see RV remodeling, RA remodeling, and she is right on the border of severe. Most of you from Medstar know that I'm a big proponent of exercise stress testing, and I think that's something we're hoping to introduce to our valve team here, because I think subjective assessments, we can fall foul of them, and certainly when patients have long follow-up periods, when they come to a valve clinic, it's a little hard to gauge. And these are younger patients by and large who are incidentally found to have TR, and they usually do fine on a bike. So we are planning to do VO2 stress testing in such patients. Again, another case, I think the echo views are very similar to this 4-chamber CMR. And one of the beauties of CMR is you can make it what you like. So we prescribed specific cut planes through the right ventricle in a 2-chamber fashion, clearly showing that regular views are probably going to miss the regurgitation here from the right ventricle to the right atrium. You see this kind of dark squirt of dephasing, and other pathologies that we've picked up during this program have been things like ASDs. So it's really important to it's really important to make sure that you don't miss such cases and things like ARVC. This patient has an incidental effusion that's unexplained as of yet. So we have started to get kind of cute and carefully follow these patients with additional imaging. Now, we haven't talked during the course of this case series about other pathologies. Here's a myxomatous tricuspid valve, really without much in the way of pathology, but has mitral valve prolapse. This is my time in fellowship. Here's a case that actually, if you look very carefully, is a ruptured cord case. Very unfortunate. This is a transplant patient. What to do with these cases is really unknown. And I think maybe not an unreasonable situation for edge-to-edge repair once we get a little bit more mature in the field. This patient has normal RV function, for example. And then lastly, two more cases. Patient with a remote history of endocarditis came for evaluation, and we see very significant tricuspid regurgitation. This is, again, to orient you, the anterior leaflet, or rather, sorry, the septal leaflet here, the anterior leaflet here, and there's really no posterior leaflet there. It's overgained, and I grant you that, but something has eaten away at this leaflet. Unfortunately, makes it not a suitable case for edge-to-edge repair. And lastly, and I didn't touch too much on this, is the interaction of leads or pacemaker leads and tricuspid regurgitation. This is a patient who has been followed by the liver transplant service at Columbia for many years, eventually came to the attention of Dr. Hahn because of this plastering of the septal leaflet, which is not present in this image, and with a giant gap here. And you can see that this is the issue. As I understand, the lead was placed emergently in the setting of VF arrest. He was unfortunately turned down for transcatheter intervention at Columbia, came over to our program, and also kind of really makes it a challenge to intervene on these cases. He's being considered for lead revision, although it's been over 12 or 14 years since the lead was placed. So these are some of the challenges that are unanswered. And I'm not sure that edge-to-edge repair is suitable, but those are some other interesting cases. I think a couple of things to think of in the future, including for ourselves at this program. I think building TE expertise is really essential. The interventionalist and the structural echocardiographer, one of the main things I learned in my fellowship was we have to speak the same language. We have to look at the same thing, and we have to be on the same team with the same goal. It's disheartening sometimes to see two different kind of vernacular being used during cases, for example. And I think that's really critical in making a procedure successful. At this time in 2020, a lot of the referrals for intervention fall into this massive and torrential category. And this is probably too late. And I hope that I made a reasonable job of showing you that we should be thinking about this when the TR is moderate. And there's enough data now to show that. So if we identify these situations early, like the two female cases I showed you with CMR, the goal is to follow them, and when the time is right, to pull the trigger and offer intervention, albeit part of a trial. But I think that's the way to go. I think we need to promote a lot more use of CMR to be more precise with our regurgitation quantification, including for MR, but just for TR is fine also. And I've been a proponent of making formal functional capacity assessments beyond just 6-minute walks and so on. VO2 assessments provide cardiac output. There's data out of Mayo Clinic showing that cardiac output is significantly reduced in TR cases. So I think this is a reasonable thing to put into practice. And then obviously offer as many patients forward for trials as possible. It's the only way we can move the field forward. And then tricuspid disease in general, just a couple of observations. Almost every patient I've seen has atrial fibrillation, and I don't know, whether this is causal, bystander, or association. But I wonder whether, we've spent a couple of decades now accepting a rate control strategy for AFib, and now we're kind of seeing the sequelae from a valve standpoint. Atrial functional MR and atrial functional TR are new things. I don't think I heard of them during residency. And I think maintaining sinus rhythm has been kind of a significant goal and almost mission critical objective in the cases at Penn from the valve program. So I think hopefully bringing that here also and see how that does. As for the procedure itself, European experience has shown us that these patients are not the same as same day or next day TAVR implants or straightforward P2 prolapse mitral clips who go home after a couple of days. Both the successful patients were in the hospital for about 8 days, getting diuresed several or tens of pounds before they embarked on the procedure. So I think the approach to TriClips are different in general. And then, as I kind of mentioned many times, this is kind of functional TR. We haven't really explored other etiologies in terms of, chordal disruption, lead-related, et cetera, and patients with pulmonary arterial hypertension who also have valve disease and TR out of proportion to their remodeling. Those kind of questions are completely unanswered. And I think basically the better we get at this, the more likely we are to answer those questions for people like Chris Barnett in the future. And the last thing is we didn't discuss any kind of annular reduction strategies, either surgical or transcatheter. I just simply don't have enough experience to discuss them. But they also seem promising. And lastly, I think I'll end with some time for questions. Wouldn't really be here without the Medstar experience in general fellowship. And then I'm really indebted to Frank Silvestri and Howie Herman, in addition to Tiffany Chen and Yuchi Han for teaching me the structural heart and imaging pieces. And then I'm kind of super excited to be part of the structural team here. Actually, the highest structural volume in the Philadelphia area, and super excited to work with Bill Gray moving forward. So with that, I think I'll take questions if you have any. Thank you.
Thanks, Harish. That was really a great overview and some really nice pictures. And with that, I'll open it up to questions from the audience, if anybody has any.
Harish, Bill Weintraub, welcome back. Great talk. I really enjoyed it. Learned a whole lot. I want to go back to your original epidemiologic observations on severity of tricuspid regurgitation and outcome. You first had it with echo, and then you sort of had it towards yet again with MR towards the end of your talk. And I think that is very likely. I think we do have to be careful that the worst outcome. We can't just say it's causal. People with more TR may have worse outcome because they have other aspects of their cardiovascular disease that are really determining outcome. And that will limit our ability to intervene and make things better by intervening on the tricuspid valve alone when everything else is going on. And you really hinted at that with a lot of things you said. So I'll just ask you to reflect on my thoughts about severity of TR and causality of poor outcome.
Yeah, Bill. Thanks very much for the question. I completely agree with you. The observational data certainly is not suggesting causality. I think it's pointing at a couple of things, and hopefully I impressed on the situation with atrial fibrillation, for example. I having seen tens of these patients now referred, in fact, close to 50. Almost everybody has AFib, and almost everybody has that I've seen in this situation has had essentially a diagnosis of permanent atrial fibrillation with, and delving back into the charts, a couple of people have had aggressive attempts at maintaining sinus rhythm. Many, unfortunately, haven't, because in the early 2000s, there's kind of data showing the other, not so robust, but data nonetheless showing that rate control is non-inferior. And I just wonder whether this, this has led to a spate of MR and TR cases. I certainly agree with you that not all severe TR is intervenable and necessarily kind of primarily causative. But totally agree.
Other questions? I don't know, Federico or Preetham, if you could reflect a little bit about your experience either here or some of the trials, Federico, that the Core Lab has been involved in, if any.
Sorry, Gabby, say that again?
I was wanting to see if Federico or Preetham were on the line and could give us some of their insights from cases we've seen or they've seen.
Yeah, hi, Gabby. Thank you, Harish. That was fantastic. I learned a lot. I will say that we don't have an enormous experience on tricuspids yet. We have a few projects, protocols that we're working on, but we are definitely struggling with this whole thing of definitions and what is severe or now, whatever, torrential and this and this and that. I have to say that there is a big push of having these new definitions of what is torrential and massive and this and that, but those are definitions that are not widely accepted within the community. So people keep talking different names for things. And as a matter of fact, I can give you some insight from the guidelines perspective. When those concepts came to the guidelines committee to be part of the valvular regurgitation guidelines, they were not particularly welcomed. Maybe we have more data nowadays, but even among experts, there was a lot of conflicting opinions there. Now, my question for you, Harish, is how do you approach these patients when they get referred to you? Do you have a specific structural heart team? Is the same structural heart team that takes care of the TAVIs or the mitrals? It seems to be a very complex and different pathology. So I really wanted to know how your structure is behind these patients.
Yeah. Thanks, Federico. Yeah, I agree with you. I think the kind of massive and torrential expanded grading probably has a little bit more data, but still has to kind of prove itself. Even going before that, I think a lot of situations where we've done mild, moderate, severe, and moderate is often splitting the difference between mild and severe. I don't think that's a kind of reasonable way to go. And I think we need definitions of severe based on outcomes that may be more helpful. For example, one of the things I'm working on with a group at Penn is left ventricular chamber dilatation in MRI. We use standard definitions of a healthy cohort. So if you look at trials on multivariate analysis, chamber dilatation often is never related to outcomes. So it doesn't matter whether you're severely dilated or not. And that's because we're using greater than 2 standard deviations above the mean. I'm not sure if there's a kind of a way to overhaul the moderate thing, because often moderate ends up being this basket of, oh, we don't have to do anything, which I kind of disagree with. But then the massive and torrential, I'm on your side. In terms of the question about the valve program, at Penn, basically there was this kind of valve group, kind of the same as Medstar, and a similar thing is reproduced here, where there's actually weekly teleconferences nowadays where patients are brought forward, discussed with actually a complete multidisciplinary team. The slides are still up here. So Sandy Abramson is the director of the Echo Lab, along with myself and Kate Hawthorne, who built the CMR program here. Scott Goldman is a really outstanding mitral valve surgeon, aortic valve surgeon, Dr. Rodriguez, and newly Dr. Ramlawi, who's a hybrid surgeon, kind of like Dr. Thurani, I guess, to give an example. And the rest are interventionalists. And I think we also have a core lab member who does CT and echo reads as a sole person. And I think that has led to a very nice interplay of discussion. I've only been here since August, but I'm very encouraged by it. It's not a single person making any decisions.
Great. We're just a bit over time. Any final questions for Dr. Jarrett?
Harish, that was excellent. This is Preetham here. That's quite comprehensive. One thing, to keep it brief, in terms of functional assessment, have you had any chance with the bike stress testing in terms of TR quantification as part of evaluation from your experience?
Thanks, Preetham. You mean to say
For the
exercise
TR
stress echo?
exercise more with the bike and assessment of TR and functional status?
Unfortunately, we currently don't have our bikes out of use. And in my time here, I haven't used any, but watch this space. I'm hoping to get some exercise stuff done with valve patients. I'll let you know.
Thank you. Thanks, Harish.
Great. Well, thanks very much, Harish. Again, that was just a wonderful overview, both on the imaging side and where we're going for treatment. Aortic valve seems to have been a slam dunk, and maybe that's in retrospect, hearing them talk about the early days of TAVI. Maybe it was a different story. Mitral has been a challenge. Tricuspid seems like yet one more challenge for us to undertake in the coming years. We really appreciate the overview and hope to run into you shortly.
Yeah, absolutely. Thanks everyone. Thanks for your time.
Take care, everybody. See you in 2 weeks.